We have a lot of questions that have come in, and I wonder if we can turn to the panel and we can ask some of the questions. I'm going to try and facilitate this, but any member of the panel, if you have something that comes up, could you please jump in and get going? And while we're talking, we can have a live interaction. Everyone on our audience, please feel free to put your questions up. There might be a momentary lag as our technology booms them or zooms them to us, and we will get to you. So the first questions really, I suppose, I'd want to pose to Jeremy. Are the determinants of vaccine hesitancy similar among healthcare workers and the general population?
Well, I can only speak of what I know, and I know the case in France. And in France, we have lots of vaccine hesitancy among healthcare workers. And there are factors that are pretty much the same as in the public and factors that are quite specific. The factors that are the same is you find the same arguments, the same fears as in the population. For instance, in the case of COVID-19, we know that the issue of the speed at which the vaccine was created, the fear of possible side effects, especially since at the beginning in France, the vaccine that was targeted for healthcare workers was the AstraZeneca. So they were hit very hard by the thrombosis events. So you have like similar determinants, but there are also very specific determinants. In France, you have very big differences, for instance, between nurses who work at the hospitals and nurses who work elsewhere. For instance, in smaller health centers or work for themselves. The latter tend to be much more vaccinated against COVID and against, for instance, the flu, whereas those working at hospital are much less vaccinated and much more hesitant. And the reason is that there's a crisis of trust between public health institutions and staff in hospitals, and it comes after 20 years of underfunding of public hospitals and things like that. So you have the same issues of trust, but within a much more specific institutional setting.
Gosh, thank you for that. We have a colleague, Suleiman from, I think, West Africa, who has a question for Professor Adiba. What do you think of the proposal from President Biden on suppressing COVID-19 patents and allow mass production?
Hi, Lorraine, and thank you very much for having me on this wonderful panel. Yeah, I think certainly the IP waiver is a huge step. Unfortunately, as we know, not all global leaders share President Biden's call to remove the IP rights for the vaccines. But to be honest, I think to really get those vaccines, the billions of vaccines that we need out into people's arms, it's going to require more than just the IP waiver. We have to really, the global north will really need to ensure that low and middle income countries are also capable, will be able to produce these vaccines. We need them now, and to find ways to improve and increase the production is really what's needed right this moment.
That's fascinating, because one of the statistics was that there's 33 compounds under trial. Do we need so many? Have we not got enough? And should we stop trying to make yet another compound for somebody else to make profit? And should we sort of just say, okay, we've got 10?
That's a really good question, right? I think, yes, we have, 5 different types of vaccine technology, and many, within that are currently being produced and tried. Perhaps it is time now to switch to prophylaxis and treatment is sorely needed. Investment in treatment hasn't been commensurate to the investment in vaccines. Yeah, and considering we're, still getting well, we're chasing the variants as well. So, more thoughts need to be given, more research, and needs to be put into searching for that antiviral.
Okay, so turning to Dr. Connor, Courtney, do you see any HIV stigma lessons in the COVID pandemic? So what are the similarities and differences?
Yeah, so I think that we definitely have seen some similarities in the ways that stigma has impacted COVID vaccine uptake as it relates to COVID, and also the ways in which stigma has impacted people's initiation of, say, PrEP to prevent HIV. I think oftentimes those who experience stigma related to COVID, those people are also experiencing stigma related to other identities. And so I think it's hard to say that COVID stigma or HIV stigma directly impact people's initiation of different technologies that are available, whether they be PrEP or a vaccine. I think maybe it's more helpful to understand how stigma in general, as it relates to people's identities and how they move through the world, impacts their willingness to engage with healthcare for all different types of healthcare needs, including COVID-19 vaccines and HIV prevention. So, for example, it may be that people who are living in areas that are under-resourced feel that they have been underserved and ignored, and now are feeling like they are being targeted, right, for COVID-19 vaccines. And we hear a lot of talk about why people who are most impacted by COVID-19 aren't getting the vaccine, and kind of some blaming, if you will, some victim blaming around why people aren't engaged in the vaccine. And I think that it's not maybe necessarily COVID stigma, but just stigma related to who these people are, how people perceive people's poverty related stigma, right? So a lot of stigma related to poverty and the ways that we think about people who are living in under-resourced areas. So I think all that to say that I think stigma in general has to be addressed, and understanding stigma from an intersectional perspective is important to understand how and why people might engage with medical advances like HIV vaccine.
Okay, maybe we've got on our panel some people who've got some amazing range of research, and I wonder if Udi or Bruno or Richard would like to comment on this issue of linking. Yeah, Richard, and then Bruno. Richard, are you on mute?
I was. The very interesting thing for me today, we didn't ask people to give presentations on a theme of inequity, stigma and discrimination. But by nature of this debate we're having, it has run through everything, and it's been a very, very powerful and common theme. Adiba, you were talking about the roadmap to reduce the inequities that still persist. Courtney, you talked a lot about pre-existing structural vulnerabilities. Jeremy, you very helpfully helped to see that these things are not fixed and that hesitancy may be or is a movable idea. So I'm thinking from the really important points you've made, we've had a really rapid decision-making 12 months, very top-down decision-making process because we've been led through a public health emergency, which of course only reveals those structural inequities even more. So I just wonder, how might things be different? How might our public health response at a time like this be different so that we don't compound those structural inequities? How might things be different?
Let's have Bruno comment as well. He had his hand up.
Well, I had a general comment and a question for the audience for the link between HIV vaccination, future HIV vaccination, and COVID vaccination. I was wondering, while listening to your fantastic talks, if the COVID pandemic is going to accelerate or decelerate HIV vaccine research. In a way, it could accelerate because of a new technology, but it could also put HIV lower at the agenda and decelerate the process. So I would be happy to have your opinions.
Okay, if you can just put a hand up if you've got a reply to Bruno, I will turn to you, or I'll just gather everyone's views. Jeremy, was that just a scratch of the head, or you? Have you got
it can be a bit more than a scratch on the head, but it's less in relation to Bruno, but more in relation to the questions before about how it might be different. And again, I'm going to talk about what I know, which is what happened in France. We had a very, very top-down, very centralized handling of the pandemic. And in some ways, there are aspects where it was positive, but there are many ways in which it wasn't, especially in creating a contact tracing system, in reaching out to communities to vaccinate more vulnerable, et cetera, And I think one of the ways that it might have been different would have been to include healthcare users, all the non-profit association, representative of patients, et cetera, in the decision-making process. The decision-making process was really centered on a very, very small group at the very, very head of the state, and they didn't really benefit that much from basically information going from the grassroots and coming up. And I think this is one source of important disappointment in the public health community here, especially since there has been very little improvement along as the months moved on. So we can make mistakes at the beginning, but when people say the same thing over and over again, after 6 months or 8 months or a year, you expect things to be done there. And it was a very state-centric and very top-down approach, and I hope that this will be part of how we write the story about COVID and why we had so many deaths in France. I hope this is what will be remembered, probably not by the current deciders, but hopefully the ones who will handle the next public health crisis.
Yeah, that's really interesting, because HIV, if the one thing it taught us was that community involvement was not only welcome, it was vital. And in fact, if you started with it, you got so much further, and it was a hard lesson. And do we always have to begin from the beginning again? I see that Adiba has a comment, and also it would be interesting to hear from Udi what's happening in the Netherlands. So Adiba, if you can go first.
Yeah, unfortunately, Jeremy, what you've experienced in France is exactly what we experienced here in Malaysia as well, that there was very little engagement of the community, especially in reaching out to, the hard to reach, the migrants, the refugees, and others. As an HIV practitioner and also infectious disease person trying to respond to COVID as well, it's really frustrating that the principles that we all abide by in the HIV response, basic things like, know your epidemic, know your response, evidence-based responses, and the human rights approach have not really been adhered to in a way in the COVID-19 response, at least in my country. And so you see that, the examples of successes in HIV, not just in other countries, even in Malaysia, when you do abide by those principles, didn't happen in the COVID-19 because the government just decided to do its own thing without those actions. And what's also frightening and frustrating is the use of the laws to in the name of public health, but in effect was detrimental to public health and rights in terms of arresting undocumented migrants, which worsens the overcrowding in prisons, etc., etc. So there are many things, unfortunately, that people in power didn't learn from 40 years of HIV, despite us shouting at them to. Yeah.
Udi, how are things in the Netherlands and all your work on PrEP?
Well, I was actually wanted to give the perspective of research, because what we've seen in the Netherlands is the huge amount of funds rushed into social science research revolving around COVID, which has actually helped us speed up and do a lot of work around COVID. And I can see that also translating into a bit of a more rapid tradition of funding social science research in general. I can see how it can generalize, but I was actually more interested in maybe Adiba or any other of the experts. Are there any actual successes, examples of successes in fighting disparities regarding COVID vaccination programs that we can take back with us to HIV already now? Are there any examples of successes? Like we can see for research.
So Udi, that's a very interesting question. And if I put it from the perspective of the UK, where they've had a peculiarly successful vaccine rollout, I think the figures today are over 81% of adults vaccinated. And they did involve social science. But throughout the pandemic, the way they involved social science was rather curious. They involved them in order to help the government dupe the public, to understand how you could tell the public things and get them to do things, rather than actually using social science in the way that Jeremy would suggest in sort of assisting the cause. And there were many social scientists who, in fact, they seemed like consumer social scientists who were telling them how to sell messages and how to convince the public. And the public were quite savvy. The public weren't stupid. And I think the public reacted. And quite interesting to contrast that to countries where maybe, for example, in South Africa, maybe Bridgette would comment on how the research and what the situation in South Africa looks like. Bridgette?
Yes. So, I guess the challenges for South Africa are always going to be economically different, though, aren't they? Because we've always got very, very different financial pressures on health investment. And I wonder if sometimes the fact that there is a higher investment from high-income countries somehow lets off the hook of people developing new science when they've got rather large, higher need and higher populations. So I wonder if some of it's about investment elsewhere, reducing the amount of investment that we have within low middle income countries.
We have a nice comment from Professor Diane Cooper in South Africa, who comments that vaccine hesitancy in South Africa exists, but the biggest problem is basically inefficient rollout. We've got Bridgette Prince on our board. Maybe Bridgette will comment on that.
Yeah, I see Di's message. There is a problem at the moment with us obtaining vaccines for all the sites. There are quite a few sites, but very few vaccines. I do, however, think there is a problem with hesitancy. And you can see that some people are not taking up the opportunity. So we've had to open up to younger groups of South Africans. And it kind of, I think, links to a number of the comments and questions or comments that were made as part of the panel. I wonder how much have we prepared our countries for these vaccines? They were developed very rapidly. And I think, if you look at the messages that have come through from AstraZeneca, blood clotting, then it is, a different vaccine. How has that impacted the way in which people feel comfortable about, going for these vaccines? And so for me, it is very much, I think Courtney spoke about it, I think Jeremy, that it is linked to the fact that there was a rapid kind of development, rapid improvement, and what does that mean?
So you bring out a bit of a double bind. On the one hand, Adipa pointed out how quickly we mobilized, yet was that too quick? And did we not have time to prepare? And maybe the answer is, once you're in a pandemic, that's the worst time to do anything. We should have been organized a bit before. And that really resonates with what you were saying, Courtney, in terms of, it really struck me of making amends if it's possible, or actually dealing with past historical problems if you're going to move forward. And I wondered if you had something to say about how we might do that.
Yes, thank you. And I'm nodding my head here with all the comments of the panelists. But I do think that, scrambling to, one, understand a pandemic, survive through it, and then develop a vaccine all at the same time is not quite the time to be developing partnerships with people and organizations that people trust, right? That foundation really has to be laid beforehand. And so, I think when we, look back on this and some lessons learned and how do we move forward, I think the lessons will be, one of the biggest lessons will be to engage the people who we seek to reach, whomever those populations are at the outset, and to be able to efficiently and quickly do that, you have to already have relationships with those people, right? So you can't just randomly call someone up and ask for some money someday, right? When you need it, you have to have a relationship with someone, and then you call them and then you ask them for something that you need. And I think it's the same. We can't ask people to just blindly have faith in a system that maybe hasn't served them just because it's a pandemic and we need them to take this vaccine so that people don't continue to die and the healthcare system doesn't continue to spiral out of control. We have to build that trust at the outset.
Yes, absolutely. And maybe to ask Adipa to reflect on, the bottom line is we actually don't have an HIV vaccine. And we are in a position with COVID-19 that we have 10 compounds, and our issues are about who will and who won't take them, how we get them there, how we make them, where's the profit, who didn't we talk to. But with HIV, where's the discussion? So I wonder, if you had a glass ball in terms of the gazing to HIV, what do you think the future holds?
Yeah, thanks, Lorraine. I think, at the IAS, we were having this discussion just a couple of days ago in terms of how can we seize the moment, if you like, of all this attention on global health to reinvigorate the search for both HIV vaccine and an HIV cure. Obviously, it will require a lot of investment, but I think we're hopeful, and certainly, the success of the COVID-19 vaccine comes on the back of, a lot of years of research, cancer research and HIV research as well. So I'm hopeful, not being exactly an HIV researcher, vaccine researcher myself. I think, I think people hopefully will be spurred to do more on the back of what's been achieved with the COVID-19 vaccine. Well, what I wanted to say also, if I may, in terms of, there was a comment, have we done enough to prepare countries in terms of getting populations to accept the vaccine? I think we scientists also need to reflect on ourselves and how well we communicated with the public. I think in the early days when the the discovery of the COVID-19 vaccine and the results of research of its efficacy was being discussed and debated both in the scientific literature and the the normal media. The scientific jargon was heavily used, and I think we didn't simplify the message enough, and even now, like the one dose is 80% efficacious versus 2 doses being 40%. You know what I mean? Courtney's nodding her head, and for the average person, who's it's like, oh wow, why isn't it 100% efficacious? Why is 98% efficacious more important than 77%? So I think there's a lot we can do to improve that scientific communication to the public, to kind of give everyone more confidence in how well these vaccines work.
There's 2 questions that have come through, and I want to read them to you because in the last 5 minutes that we've got, it would be lovely if everyone just sort of commented. So Shanaz Pahad says, how much about vaccine hesitancy is a result of the mental health strain from the pandemic as well? And I think that's a very perceptive comment. And indeed, our next webinar in November is going to be on mental health. But it's really a fascinating one. And Christopher Sanford says, do you think the sensationalist reporting, social media and the imagery during the COVID pandemic fueled fear and therefore fed into the fear of vaccine? So I wonder whether, I see Jeremy has a comment, but it'd be actually nice at this point to just go around everyone. So Jeremy, the floor is yours.
I'm going to try to be quick. I'm going to start with the question of reporting and social media. I think really it's not that much. So sensationalist reporting went both ways. It actually was important to create fear of the virus, especially in some moments when maybe lots of people didn't see the reality of the danger posed by the virus. But at the same time, in some cases, it could be focused on the issue of vaccine safety. In France, we didn't see that much sensationalist coverage around the issue of vaccination. And I just think that it's important to see that, in general, the past year and a half was a period of what some people call infodemic. We tend to focus the idea of infodemic on social media, misinformation, fake news, but mostly it's just about lots of information that is a bit contradictory and lots of uncertainty, because there is scientific uncertainty and changes in what scientists believe. So I think that there was no way of avoiding that. And I think there could also be the opposite tendency of trying to get a very simple message out, but a message that would be mainly lying. Because when there's uncertainty, it's important to say that there is uncertainty, and mostly the public can live with that. And I'll stop there.
Great. I know we have the excellence of Dr. Bruno Spire, who's both a virologist and one of the world's leading HIV social scientists. I wonder if you had some words for us, Bruno.
No, I still think that I hope that this epidemic will help HIV vaccine development. Lorraine, you said that that we don't have a vaccine, okay, but maybe this mRNA technique will help the arrival of a new vaccine. And as Adiba said, I think it's time to take this opportunity to put also HIV vaccine research on the top, because I think there is still no cure, no vaccine, and the difference with the COVID, there is no spontaneous cure as well.
Yeah. Fantastic. Very, very important. Richard, you've got such great experience. Do you have something to bring to us from your work?
It's very interesting. I'm just thinking about the 90s. There was an advertising campaign from an HIV prevention organisation in Germany called Deutsche Life. And it was of a naked gay man with KS lesions all over his body. Now, that type of health, I can remember you nodding, Udi, you remember it. So that type of advertising did not really take off in HIV prevention, and we don't do it in cancer, actually. All the health promotion activity we do in cancer, we don't show people with cancer. That's not what we do. And I wonder how how much of a positive driver fear is. And the problem with COVID is, gay men will know other people with HIV, the general population will know somebody with cancer, but the likelihood of actually knowing somebody with an admission with COVID or a death from COVID is actually quite unlikely. So I think the problem is when you drive with fear and then people can't see that fear, I think it feeds all kinds of misapprehension. I think it's probably quite problematic.
Udi, your final comments as we...
Yeah, I think what we've learned from HIV as social scientists is the enormous hunger that communities have to have a certain social norm to relate to. And I think we see it very much in COVID, and especially in an emerging disease. People want to know what other people will do. People want to know what other people think it's best to do. And I'm just curious, and maybe Jeremy can comment on that. Whose role is that in forming the community norms? Can we as governments or can we as public health professionals help that form that norm? And what is actually the secret? Because if you look at what Richard just commented, the safe sex norm, the condom use norm in the late 80s, early 90s, it was definitely a norm which was embraced by the community itself. Is there anything we can do about it or learn about that in terms of COVID? In how do we induce such a norm for vaccination?
Oh, a tall order. Bridgette, do you have some closing comments for us?
I'm good, thanks.
Lots of views coming around. Courtney?
I think I would just echo what other people have said, but also I think when it comes to the norms, when it comes to fear, I think we have to be careful about fear. I think fear can drive people to be vaccinated, but I also think fear can kind of fuel stigma as well. And so I think we have to be careful about how we effectively communicate the risk to people and their risk, and not kind of lean over into fear mongering, right? Because that can also lead to othering the disease, right? Like, so now we have HIV has transformed from primarily being seen as something that affects gay men, right, to now being something that affects kind of the poorest of the poor. And so as and we don't want the fear and the perception that people are responsible for this disease or their disease to impact people's ability to kind of receive vaccines as they become available.
Thank you. So our last words, Adiba, you've been put onto the WHO committee, and I wonder there's a huge responsibility on your shoulders, and we look to you, rightly so, because you're so attuned to the issues. And I wonder what you see as the biggest challenge facing you.
Facing the world, did you say?
Yeah.
Oh, well, I think, as it goes back to the topic of my presentation, and that's the inequalities, right? That COVID, it's always been there, but COVID has really, really put a spotlight on it, whether it's global inequality or inequalities that exist nationally. Yeah, and there's no easy answer, but since all of us have been affected by COVID-19, I hope and I pray that at least, there's reflection and, at national level, at global level, that if we don't reduce this gap, that in the end we all will pay the price.
Great. I think we've had the privilege of such an amazing team of expertise and perspectives. I think we're all shivering under the shroud of what COVID has done to our world. And we've really got to think that from tomorrow on, it's a new reality, a new reality that COVID has changed things, but we still have options. We have to just absorb them and move forward. The discussion and the dialogue has been really interesting, and some of the lessons of equity, pensiveness, inclusion, community dialogue, and thoughtful theory, not fear arousal, panic and hype. We know from HIV that fear arousal doesn't do anything, but we do know that humor does quite a lot. And we also know that resilience, even when you cannot find anything, just pops up. You know, we know that when adolescents had nothing, what did they do? They went into the markets and sold masks. So I think we remain really hopeful that humans are more than a reaction to a virus. They're a community. And we hope that you will take some good lessons away. This will be available on our enduring material. And we just look forward to the next step in our dialogue, which is where we're going to try and unpack some of the mental health issues around HIV in this current era. So I don't have an audience that we can clap our speakers, nor to clap our wonderful board who've given such support. But thank you, and especially to Virology, who've hosted this to the most amazing quality level. Thank you, everyone.